Hi, everyone. Welcome back to another episode of CHD Unpacked, a podcast about living with congenital heart disease. This podcast is brought to you by the Canadian Congenital Heart Alliance. I'm your host, Amanda, and today we'll be talking about the impact of health systems on access to CHD care in the Prairies. We're very honored to be joined by today's guest, Dr. Michelle Keir. Dr. Michelle Keir is an adult congenital heart disease specialist and an echocardiographer with a background in communications. She holds a master's degree in population science, and her clinical and research interests include ACHD, heritable aortopathy, and mixed methods patient-centered design. She is an associate professor in the Division of Cardiology at the Libin Cardiovascular Institute at the Cummings School of Medicine in the University of Calgary. Please join me in welcoming Dr. Michelle Keir. Hi, Dr. Keir. Welcome to CHD Unpacked. Thank you so much for being here today.
No problem. Happy to.
So today we're going to be talking about the impact of health systems on CHD care in the Prairies. To start off, can you just tell us a little bit about the scope of your practice?
Yeah, so I am an ACHD cardiologist, and I also do echo. I work in Calgary. So I'm at the Libin Cardiovascular Institute in Calgary.
Great. To start off this topic, can you outline the components of a health system and how that can have an impact on someone's access to care?
So, we say we have a public system and we call it the system, but I think there's lots of kind of different circles of healthcare. At the core is kind of the hospital-based care. So congenital surgery, kind of in-hospital acute care. And then there's also kind of the wider network. So, one of the things we do in our ACHD clinic, we are located in a hospital, but we are an outpatient clinic. And so we see people here, and that includes our physicians and our non-physician colleagues. So there's ACHD cardiologists. We also have a multidisciplinary clinic where we work with a hepatologist. We have respirologists that work with us. And then there's also our amazing nurse clinicians and nurse practitioners. So all of these people are kind of part of the care. And then there's all those allied health supports as well. So we don't have a psychologist or a psychiatrist on site. We do have a social worker and then access to psychiatric services. So that's also part of that care. And then I think another big part of the system is all of the kind of administrative work. So, booking patients for appointments, booking patients for diagnostic testing. So making sure that they have their MRI at one hospital and their echo at the right place and that sort of thing. So there's a lot of work that goes into it there. And then I think there's also the wider systems that often fail our patients. So systems of, pharmacy and prescription drug coverage, dental care, the things that you need for daily living. So food insecurity and making sure that our patients have enough gas to get to appointments and that sort of thing. So I think all of those things fit within this wider system. And then there's kind of smaller and smaller circles. And we tend to focus on just the hospital-based care and the clinic care. But I think all of those different things that come into that system impact patient health, especially ACHD patients.
Sure. And can you comment on why the logistics of a health system are so important in a condition such as CHD?
Yeah, so A is because it's a lifespan condition. So, this is not something that it's an acute illness you have it once and you never need it again. It requires lifelong care, right? So we follow patients through all of those phases of life. So there's the pediatric care and then they transition to us in adult care. There's, the non-cardiac issues that come up where they also need the input of the congenital doctor. So pregnancy issues, we follow patients during pregnancy, non-cardiac surgery, we follow them when they're admitted to hospital for other things as well. And so I think the complexity of congenital heart disease patients and people living with congenital heart disease is anatomy. The other thing that I think makes it complex and why the system is so important is lack of awareness of congenital heart disease among non-cardiology practitioners. Not just ACHD practitioners or cardiology practitioners, but kind of emergency room physicians and ICU physicians and family physicians. There are so many more congenital heart disease patients that are living well with the disease, but it used to be this kind of rare disorder. So, I remember when I went to train in ACHD and somebody said to me, why would you spend 2 years doing that? You'll see like one of these patients in your career. And it's like, no, but we have thousands of patients, right? So I think the system itself the congenital clinic is kind of the core, and patients should know how to get to us and how to reach us. But there's lots of issues within that wider system that are a challenge for congenital patients, and we are failing patients living with congenital heart disease in a lot of ways.
Mhm. And I think teaching sometimes needs to catch up with like the evolution of practice. And like you said, it used to be thought of as this really rare condition, and it's really not. So I think that the awareness piece can really go a long way in terms of connecting different allied healthcare resources.
Yeah, absolutely. And I think we try to do a lot of, outreach education with our colleagues, and our Emerge colleagues here in Calgary have been great with that. And our ICU colleagues and CVICU colleagues, and saying, you are going to see these patients, and they're coming. The tsunami of congenital patients that we all talk about is here. And so making sure that we're working with all of those partners to make sure that everyone is able to and ready to care for these patients. Because I think, it can be really daunting to look at a chart and see history, the surgical history and the cardiac anatomy, and what does all of that mean? I think one of my colleagues, we were all joking last week because we got a referral from somewhere, and the physician's note, it was an internist that had said, this patient was admitted to hospital, and we found out that their heart was completely crazy. And we were like, yeah, that's actually a good description. More detail is important, but you're right. It is completely crazy. And so I think like developing a comfort level with all practitioners with congenital heart disease is a real priority.
For sure, for
Yeah.
sure. And can you comment on some of the barriers that someone with congenital heart disease might have in terms of accessing care in prairie regions such as Saskatchewan, Manitoba, and Alberta?
Yeah, so I think that one of the big ones is lack of access. So we know that probably up to 50% of patients, adults living with congenital heart disease, are lost to follow-up care. Some of that is, that pediatric conversation, or that a lot of patients just don't know that they're supposed to be followed. And then I think when we do get patients back into care, or when they are transitioned, the burden of testing and the number of appointments for is a huge barrier for young patients. I also have a general cardiology practice, and I always think for those patients, we can call them and say your echo's Tuesday at 2 o'clock, and they're like, okay, because
Yeah.
they're retired, right? They don't have
Yeah,
a lot of other things to do. They're happy to come for their echo appointment, but for young people, they have school and work and family obligations, and life is just so much more complicated. And so to have a disease that requires long-term attention and longitudinal testing, it's a real challenge. So I think timing and the way that our system works is difficult as well. A lot of our patients, like, we're still using letter mail,
hmm,
and for a 20-year-old, like, they're saying, well, my dentist texts me when my appointment is and texts me a reminder. Why can't you text me? And, so those are things that we're trying to overcome. So there's a real disconnect between in communication as well. And then I think there's all the structural barriers. We know that there's not enough congenital heart disease specialists, especially in adult care. It's something that's being worked on, but the workforce is just not there. So we always say we want to bring that 50% of lost patients back into care, but sometimes I'm like, because where do we put them? Like, there's not enough of us, right? And so that's another thing that's a barrier, is finding a cardiologist that has the expertise to manage your condition. That's tough for people too, right? Navigating what that means and what that looks like, and what's the difference between an internist and a cardiologist and an ACHD cardiologist, right? So all of those things I think are barriers.
yeah, and especially for someone that has CHD and maybe weren't aware that they needed this kind of follow-up, so they didn't ask the questions at the time. How do I connect with someone, in future years if I have questions? How do I connect with a cardiologist if I've been lost to follow up, So, and kind of getting back into the circle of care seems like a huge hurdle for someone in that position.
Yeah, absolutely. And we kind of catch a lot of people in different ways. So, pregnancy is one of the big ones. So, a woman might become pregnant and didn't know that she needed longitudinal congenital care. And so we work really closely with the obstetricians. The ones in Calgary are amazing. And they'll call us and say, we're like, yes, we need to see them. Our cardiac surgeons are amazing as well. When they get a patient that has residual disease, that maybe their family doctor did an echo and then sent them to a cardiac surgeon, they'll say, no, like we're going to redirect you there. And we catch people in hospital. But a lot of it is piecemeal. And there's no one size fits all way to get people back into care once they've been lost.
Mhm. And I guess it would vary as well, like how much care someone would need depending on their type of lesion and, the surgeries they or procedures they might have had as well.
Yeah, exactly. Yeah. Yeah. And we have people routinely that, they'll say, well, I saw this other cardiologist and they said everything was fine. And then they see us and we're like, oh, actually you need surgery. But so I think that's knowing kind of who has the expertise to manage your condition is tough too, right?
Yeah, for
Yeah.
sure.
Well, even so I mean, we didn't talk about this, but Canada is a big country and there's a lot of patients that don't live in major centers or large cities. And we have a large rural population in Alberta. So in Calgary, our population is about 1 million, but the catchment area is 2+ million patients. And so we have a lot of patients that are coming from smaller towns or cities or really living rurally. And they'll call and say, well, like Lethbridge is 2.5 hours south and there's a cardiologist there and they can do an echo. Why can't I just see that person? Right. Or, they can do an MRI in this town. Can I just have my MRI there? Or city. So I think that's a barrier too, is, really, like I wish we could do outreach clinics in all of those communities, but we don't have the capacity to do it. And so, and a lot of the cardiologists there will say like, oh no, we can't actually see you. You need to go to the city. But that's difficult for people, right? It's hard to understand why I need to make this trip in to a bigger city when I have resources available, right?
Yeah. And for people traveling those distances, it's the money for transportation, it's time off of work. If it's difficult for them to take a sick day or to take a day off of work, like that's a really big deal. And especially if there's not, I guess, communication as to how important that follow-up is, it can be really difficult to kind of follow patients.
Yeah. And we try to work with people and say, well, you can have your echo on the same day and we'll try and if you're from out of town and we'll try and schedule around you. And, we all will say, okay, well, I don't do clinic on that day, but I'll see a person on this day if they're coming because I'm reading echo that day, that sort of thing. But it really it's a lot to juggle and it's tough. And we get that for people that, coming to make this appointment, it's routine for us, but it's not always routine for them and they may need to make sacrifices. And I think all of those things you said, like we say we have a public healthcare system, but healthcare is not free, right? So traveling to these appointments, you need a car, you need gas money. If you don't have a car, you need a friend that can drive you. Parking is $15 for 3 hours because our office is in the hospital. If you need to come up for multiple tests, the MRI is at a different hospital than where our clinic is. And so all of those things, and you're right, taking time off work and sick days, and you're losing financial income that way. So for young people, these are really big barriers. And so we say we have a public healthcare system that's free, but it's not really free, right? And all of those things have to be factored in.
Yeah. And I think people talk a lot about social determinants of health and that how that is a really big indicator as to how someone might be able to prevent their risk of future complications. Can you comment on other social determinants of health that come into play within the region that you practice?
Yeah, I think, so food insecurity is a big one. I think finances right now, with everybody being stretched with household finances and inflation, are really difficult. We did a study when I was a resident in Saskatchewan where I called patients and we looked at a whole bunch of socioeconomic factors, and I remember speaking to a couple of patients who had significant food insecurity, and the question is, in the last month, how many times have you run out of food and not been able to buy more? And you think, oh, well, nobody's going to say yes to that question, right? Like people are tight, but there were some patients that said, yeah, I have food insecurity. And then you think, okay, well, that person lives in the far north. And so if you can't buy lunch, why is attending your cardiology appointment going to be a priority, right? And so I think until we address those social determinants of health, then people can't access care. Because it's just, if you're living day to day and trying to survive, then your long-term outcome is not a priority, right? So yeah, absolutely. The social determinants of health and insecurity and financial insecurity and poverty really play a big role. I think we have a large Indigenous population in Alberta, Saskatchewan, the, the terrible history of residential schools and trauma and so-called Indian hospitals and the real trauma associated with getting healthcare. As an Indigenous person, I don't think we can state enough how difficult that is. And so really just racism within the system is another barrier to healthcare for our Indigenous patients, and kind of how do we overcome that history and try to get people the care that they need. It's very difficult.
Yeah, it's very complex. And I think everyone's intersection of the different things that might impact them is going to create a very unique picture. So, someone who struggles with food insecurity, someone who has struggled with racism in the healthcare system, someone who struggles with poverty or they don't have access to transportation, all those different combination of factors are going to produce different outcomes for people. So, I think it's really important to try and vocalize that to your healthcare team for people that are struggling with any of these things, as much as you feel comfortable to do so, to try and help mitigate those factors. Like you were saying, potentially being able to see your ACHD cardiologist on a different day than clinic usually runs, or just trying to make exceptions for those cases.
Yeah. And I think that, we want to hear that from patients. I think one of the things we found in focus groups was a lot of our patients said, oh, well, like, why would I talk to my cardiologist about that? Like, that's an appointment about my heart. Like, why would I tell them the other things going on in my life? And we really do want to know that because it impacts everything else, right? And, I can't fix food insecurity or housing insecurity or racism. I mean, I wish I could fix it, but we can't. But knowing about it is important because then it frames kind of how we help those patients navigate through the system. I have some patients with extreme health related anxiety, and, if their appointment is delayed by a month or so, I had a patient that, called and was anxious. And so it came off to our admin staff as, oh, this person's really angry. And it's like, no, they're not angry. They have extreme health related PTSD and anxiety from their childhood surgeries. And so the fact that we've moved their clinic appointment petrifies them. And so they're afraid, right? And so I think knowing that about people and knowing where people are coming from is so important in how you care for them as a whole person. I have one patient that I will never forget. She would come to clinic and we would ask about her, her relationships, and because we were talking about pregnancy and what's going on in your life and that sort of thing. And one time she said, I used to think that you just really cared about me as a person and wanted to visit with me, but apparently this is all medical stuff. I was like, no, we do care about you as a person, but also, yes, it impacts your medical care, right?
Yeah.
So I think there's all of those things people think, well, that's not the purview of a medical appointment, but often those things can be more impactful to your long-term health than your original anatomy, right?
Yeah. I think sometimes when people have poor experiences with the healthcare system at some point in their life, it becomes very easy and natural to make the assumption that it's going to be like that in any other appointment that they have, right? So it's upsetting to see that, there's a lack of trust inherently within the healthcare system because of
Yeah.
that.
And I think there's, the more exposure you have to any system, the more chance there is that you're going to have had one or multiple negative experiences. And so our job is really to try and overcome that and kind of repair some of that damage that's been done. But yeah, when you've had a medical issue your whole life, you've had lots of contact with the healthcare system, and healthcare workers are people. And so, there's going to be some that had bias or that weren't the nicest, or, maybe handled things wrong. And it's really hard to keep coming back, right? When you've had a negative experience. And so it's, if you go to a restaurant and you get a bad meal, you never go back to that restaurant. But if you have a complex cardiac condition, there's one restaurant.
Yeah. Yeah.
So we try to make it as welcoming as possible. But but yeah, it's tough. And all of those factors come into people's long-term care and outcomes.
Yeah. And in taking all of these things into consideration, do you feel like overall there's a discrepancy in the quality of care that someone receives depending on where they live in Canada?
Yeah, absolutely. I think, yes, we'd all love to say that care is equitable throughout the entire country, and that's the goal, but we just know that it's not true, right? So I think, all of those things we talked about, if you live in the city, your access to care is better than living rural, right? Really specialized care, or you need some financial means to overcome that access issue. There are places in Canada where, it can take a year or 2 years to get an echocardiogram. I know, my colleagues that work in Winnipeg, the access to an echo in Manitoba can be months, if not a year wait. Whereas in Calgary, I can get an echo tomorrow if I really need one, or next week. And so there are real differences in access across provinces, in town cities, across the country. And so if we don't say that we know that's true, it's hard to overcome those.
Yeah, I agree. If we try and kind of have an overall blanket approach to looking at healthcare and saying that, it's free across Canada, so that means everyone's going to get the same healthcare, we're kind of missing the mark in terms of making things equitable. The terminology equal versus equitable is really important to use because yes, it's equal access in terms of, not paying for it, but it's not equitable in terms of who can actually access it.
Yeah, and if I think it's very easy. I mean, it's the same thing with lots of things in Canada. Like we're nice, we don't have racism in Canada, and we're nice and we don't, none of these problems exist. But if you deny that the problem exists, then you never repair the damage, right? And so I think those inequities are definitely there. And I think the rhetoric that we have this great public healthcare system and everybody has equal access is really, really misses the mark and fails our patients because we don't have equitable access. And, we also know a lot of our patients have neurocognitive challenges from pediatric surgeries and from other illnesses and disorders. And, we know that the care is not equitable for patients with neurocognitive dysfunction. Just executive function and making appointments and following up. It's a lot of work. And so I think that when we say, yes, we have this great system that's free for everyone, we're really missing the opportunity to improve.
Yeah, I completely agree. And I think it's so important to spread that message. It really comes from a systems approach, like you were describing. It's more than just the doctors that are able to provide care and the nurses and the nurse practitioners. It's people that decide, how healthcare is delivered in
Yeah.
general.
Yeah. Yeah. I think a great example is dental programs. So, we know that a lot of patients with artificial material in their heart are at big risk of endocarditis or infection on the heart valves or heart material. And I have a lot of patients who don't have access to dental care because they don't have an employer that will pay for it or an insurance plan or their parents' insurance has run out. And so that provides a real risk of having endocarditis and needing another heart surgery.
Yeah.
And so, if that person comes into hospital with an infected heart valve, I can, get a surgeon to do a sternotomy and give them another valve, but I can't I can't give them $300 to go for a cleaning. And that's one of the things that's really disappointing is we see that, healthcare is not just hospital care or physician care. It's these whole multidisciplinary teams. And if you don't have access to one piece, it can cost so much in other, the cost of the patient of having another heart surgery and, being septic and endocarditis, but there's also the cost of the system. And so you think if we just, paid $200 for a cleaning, then this wouldn't occur, right? So we grapple with those things, and it's difficult. I think in Alberta, there's the new federal dental plan, and our premier just said that we don't need it in Alberta, and we're not going to take federal money. Like every week I have somebody in hospital every time I do a service week with an infected heart valve, not just congenital patients, but general cardiology patients from poor dentition. And so, the thought is, well, we don't want to pay for it. We are paying for it. The system is paying for it, and those patients are paying for it. And everyone should have access to dental cleaning.
Even if you take the human aspect out of it, apart from the fact that this person is now suffering much more medicalization than they would have otherwise had to endure.
Yeah.
The cost of the system is much more because the cost of a cleaning versus the cost of admitting a patient to hospital, having a surgery, the post-operative care, the medications that they'll receive in order for that to happen. Like the system is saving money.
Yeah, like I'll have patients in hospital with an infected valve and I want to send them to see a dentist and they're like, well, that's not covered. And it's like, well, like we're going to put a new fresh valve in.
Mhm.
Please fix their tooth abscess.
Yeah.
But they're saying, well, the patient has to pay out of pocket for that. And oftentimes they can't. And so it's just such a weird disconnect because, we're paying $1,000 a day for them to be in hospital and they're in hospital longer and at risk of further infection because we won't pay for this other piece, right? And so yeah, we see that a lot. And I think with young congenital patients with all of these challenges that all plays into it. We know that employment is difficult because of all the appointments and unexpected heart issues in patients living with congenital heart disease. And so often they don't have as much secure employment as the average person. And if you don't have secure employment, then how do you have a dental plan, right? So it's kind of this circle of inequity that's really difficult to overcome.
And I think it's really important to kind of stress that to government systems as much as have the power to kind of advocate for patients that they see on a day-to-day basis.
Yeah, I think it's hard to not want to advocate and not follow politics and saying when you're caring for people every day. There was a cardiologist on Twitter that posted, oh, we need to be apolitical. This was in the States, so that's, different. But and you just think, well, we can't be apolitical because these are issues that affect our patients on a day-to-day basis. And, yes, I can take care of this one small part of their heart or their anatomy. I can take care of this one small piece, but there's all of this other stuff that's missing. And so how does the system take care of that, right?
For sure. So, given this decreased access to care that we've kind of been describing for people living with ACHD, what role does patient education and counseling play in ensuring that someone is receiving adequate care?
I think it plays a big role. So I think that patients knowing that the system may not be perfect is really important because then it helps them advocate for their own care. I remember I did a survey of patients and there was a young man that was lost to care and we had called him to do a survey and I said, well, you haven't seen anybody in 2 or 3 years. And he said, oh, well, I figured they'd call me, like they'll take care of it. So if they didn't call me, I don't need to be seen. Right. So I think, yes, we want people to have trust in the system, but also know that it's not a perfect system and there are weaknesses. And, we may have switched to they may have switched to a new EMR and didn't call you or called the wrong number or so knowing that, this is what my follow-up plan is, and, this is when I should be seen. And if I haven't heard calling, we welcome that, right? And it may just be, yeah, we're a little behind. We'll see you in 3 months. You'll get a call and that's great. Or it may be, oh, we've been looking for you. We lost your number. We tried to call you at this different ad, or we sent stuff to this address. So I think that patients knowing that the system is imperfect and being empowered to advocate for themselves is important. I think one of the other pieces is, if you feel like you're not getting along with a practitioner or their values don't align with your values, knowing that, hey, like I can ask for somebody else, right? We have different genders in the clinic and different ethnicities. And so sometimes people will say, hey, I would feel more comfortable with this person. And we always go, yes, absolutely, of course, right? So I think just the knowledge that you're the boss kind of thing, if that makes sense. And being empowered to ask those questions and to say what you need. And then also knowing that the system is not perfect and that, keeping track for yourself is important. Because ultimately the person who cares most about their health is the person who's living in that body, right? So yeah, I think it's important.
Mhm. And I
Yeah.
think healthcare is kind of made a shift in that way over the past, few years where there's a greater emphasis on a patient being in the driver's seat. So I do feel like we're going in a good direction in that sense, but it can always be improved.
Yeah, absolutely. And I think that, the work that our pediatric colleagues are doing on readying patients for a transition and working on advocacy and self-efficacy and asking those questions and, knowing how to talk to a healthcare practitioner, those are being able to ask a question that's meaningful to you is just as important as what your original anatomy was, right? So, so I think that's really important. One of the things we often tell people is that, when you go into the emergency department or you see a new family physician or another practitioner, you probably know much more about your heart than they do, right? And so that can be daunting to say, well, this is what's different about me. This is what I need, draw blood cultures, please do a CT, that sort of thing. It can be really tough, and not all healthcare practitioners take that well, right? But empowering patients to advocate for themselves and ask the right questions and know that oftentimes they are the expert on their own healthcare is really important. And I think another piece too is sussing out where people are. So, there are some patients I have that are like, I want you to just tell me what to do and I'll do it. I don't want to think about it. I don't want all the options. And so, so kind of having that conversation about how people want to receive information. Then there are patients that say, you know what, I only want to know if I need to worry about it. Don't worry me in advance. But everybody's different. And so I think kind of knowing where people are coming from and saying, my style is more where I'll tell you everything. Is that what you'd prefer? What are your values, your preferences for receiving healthcare information, for participating in your care? And some people will say, look, I'm going to come here once a year. We'll have a chat. You tell me if there's something wrong. And then there's other people that want to know all the details, right? And I think knowing that there's not a one size fits all, not one way is best. Everybody's different, and being able to tailor that approach is also really important.
For sure. And I appreciate you saying that, because I think sometimes people need to hear it from a healthcare practitioner in order to feel like they can speak up about things that are bothering them, or they can request a certain style of interaction with their healthcare practitioner.
Yeah. And I think that, I've had patients, so I also do genetic aortic disease. So different, but, a lot of these patients are at really high risk of having an aortic dissection. And it's tough to go to the emergency department and, have them say, oh, we did blood work and your chest x-ray looks good, so you don't need a CT. But they know I'm having chest pain. This is different. I have this genetic condition. So it's hard, and it's a skill. And so I think empowering people to know that, that they may not know about as much about your condition, or say, hey, can you go check my clinic letter? Or here, I have these instructions from my cardiologist that I'm supposed to do this. All of that kind of helps. And it's not easy, but it is a real skill.
For sure. Yeah, I completely agree. In some of the barriers that we discussed to even accessing care previously, especially in the prairies, can you propose any solutions that you think are feasible for people to have greater access to care within this region?
Yeah, I think communication is a big piece of it. We don't have any qualms about saying, this person needs some care that we can't provide here. We're going to send them to our colleagues in Edmonton. I think that kind of open lines of communication is really important so that patients end up where they should be. I remember as a fellow in Saskatchewan, we had a complicated Fontan patient that probably needed to be worked up for transplant. And they were saying, well, I'm going to call my colleague in Edmonton who I knew and say, we should send this patient. Every center is not the same, right? And different people have different expertise. And so I think education about that, advocacy about that, and then also just having open communication. We'll send patients to Edmonton for surgery, and it's not because I don't think Calgary is a good system, or that we're not a good clinic, or that we don't have a great hospital system. There are certain things they provide that we don't provide, right? So I think that's important to access as well, is just really open lines of communication and saying, okay, I don't have this available to me, but I know how to get it, is important too.
Yeah, for sure. And can you comment on how care for ACHD has evolved over time in the prairies?
There used to be a push, like there were a lot of things to, to have congenital surgical centers everywhere. And really because it's a rarer disease, just like everything, outcomes are better if the expertise is in one spot. So all of the congenital surgeries that happen in Western Canada, aside from BC, so Manitoba, Saskatchewan, and Alberta, happen in Edmonton. And that improves outcomes. That is also a big barrier. So we're only 2.5 hours down the road from Edmonton, but still it's difficult for people to get there for surgeries if their family is here. So it is it is a blessing in that outcomes are better, but it also is a barrier to access. I know for patients coming from Manitoba, getting to Edmonton for surgery is not easy, right? When your entire family lives there, your support system is not in the place where you're having surgery. So that's kind of, and that's true for a lot of people in all over the country. Quebec, if you don't live in one of the major centers, for most of Ontario, almost all of Ontario, Toronto is the surgical center. So having to travel long distances for care is difficult.
And for someone living in this area where if they're trying to look for more resources and they might feel overwhelmed by trying to access care, do you have any recommendations for them or any advice?
Yeah, I think CCHA is amazing. So reaching out to people there. The ACHA in the States is also really good. They have a list of centers. So you can look up, where is the closest center. Anytime I have patients that are traveling, if they're only going for a month or 2 months, they don't need an appointment, but I always say you need to know where the closest ACHD center is. So if you run into trouble, you can say, transfer me there. Having that knowledge and knowing where to look that stuff up is important. And I think, there's CatchNet, so the Canadian Adult Congenital Heart Network, that shows all the centers, and we have everybody listed there. So if you're in Canada and you want to know where the closest center is, you can go to the website and there's a map there. And then I think also just, reaching out to local clinics and saying, hey, I have this condition. Do I need to be followed here? Can I be followed somewhere else, et cetera? We're always happy to answer those questions. And we do find people that way, where, we'll get a call and they'll say, hey, I feel like I should be followed up, but I haven't seen anybody since I was a kid, or I moved and I got lost. And so people do come back to care that way. And I think exactly kind of what you had said, is not being afraid to ask questions is really important. So sometimes we'll get a note from a family doctor like, oh, this person has repaired heart disease, but they're insisting they need to see you. And we're like, yeah, because they're right. Like we do need to see them. If you get an answer that doesn't make sense to you, asking questions or saying, oh, I'm going to call somebody else, or I'm going to ask somebody else, is important.
For sure. Thank you so much. I think that's really helpful, and it puts into perspective for anyone with CHD that there's multiple avenues to go down to receive care, and it's important to ask questions and kind of put yourself in the driver's seat in terms of the care that you do receive.
Yeah, absolutely. Yeah. Yeah.
Well, thank you so much, Dr. Keir, for joining us today and providing us with your expertise. It was a pleasure to speak with you.
No problem. Thanks.